The kidneys play an important role in the body. They filter the blood, removing waste products and excess salt and water. If the kidneys become damaged, they falter in their task, causing fluid and waste to build up in your blood, leaving the blood polluted. Finding out that you have early diabetic kidney disease can alert you that your kidneys are in danger. It is important to take steps to protect your kidneys before the problem advances. People who develop diabetic kidney disease usually have no symptoms early on. Diabetic kidney diseases usually cause no symptoms until at least 75% of your kidneys' function is lost, and people who have the condition often produce normal amounts of urine. Doctors rely on tests that measure a protein called albumin level in the urine and blood tests to evaluate the level of kidney function. When the kidneys are working normally, they prevent protein from leaking into the urine, so finding protein in the urine is a sign that the kidneys are in trouble. You may be told that you have microalbuminuria or moderately increased albuminuria. That simply means that you have trace amounts of protein in your urine. Key complication of diabetic kidney disease is more advanced kidney disease called chronic kidney disease. This can progress, eventually leading to kidney failure and the need for dialysis or kidney transplantation. Treatment: keep your blood sugar in the right range, usually with hemoglobin A1C target below 7%. Keep your blood pressure below 130/80, especially if you have more than 300 mg of albumin in your urine per day. Doctors usually recommend specific types of blood pressure medicine for people who have diabetes and kidney diseases. Examples include ACE inhibitors and angiotensin II receptor blockers, also called ARBs, because they decrease the amount of protein in your urine and can prevent or slow the progression of diabetes-related kidney disease. Side effects include possible dry cough, allergy, and high potassium level. Your doctor needs to check your blood test a few weeks after starting either of these medications. Women who are pregnant or attempting to get pregnant should not take ACE inhibitors or angiotensin receptor blockers, as these can cause birth defects. Lifestyle changes can also help. Limit the amount of salt you eat, quit smoking, lose weight if you are overweight. Even small changes can make a difference. Get at least 30 minutes of exercise activity on most days of the week. Lower your cholesterol, eat less saturated fat. Avoid medicines called NSAIDs or anti-inflammatory medications such as ibuprofen or naproxen, as this can cause kidney damage. Call your doctor now or seek immediate medical care if you have new swelling, blood in your urine, much less urine than normal, or if you have no urine. Thank you for listening. If you like this video, please click the like button, hit subscribe, and ring the bell. Be healthier.
SGLT2 inhibitors explained in 3 minutes. Let's begin. The SGLT2 inhibitors, or sodium glucose cotransport 2 inhibitors, are one of the newer medications used to lower blood sugar in patients with type 2 diabetes. These drugs can be identified by their suffix gliflozin. For instance, empagliflozin, or its brand name Jardiance, or dapagliflozin, or canagliflozin. So, how exactly do SGLT2 inhibitors reduce blood glucose levels? But firstly, what is SGLT2? Sodium glucose cotransporter 2 is a protein found in the nephrons of the kidney. Approximately 160 to 180 grams of glucose is filtered from the glomerulus into the Bowman's capsule in a day. SGLT2 is a protein in the proximal convoluted tubule that acts to reabsorb filtered glucose back into the blood. Approximately 97% of filtered glucose is reabsorbed into the body through SGLT2, and the remaining 3% is reabsorbed through another protein called SGLT1. As a result, very little glucose is excreted through the urine. As the name suggests, SGLT2 inhibitors, such as empagliflozin, bind to SGLT2 and prevent the reabsorption of glucose back into the body. As a result, more glucose is excreted through the urine, and this results in a reduction in blood glucose. So, to summarize, SGLT2 inhibitors act to decrease glucose reabsorption in the kidneys, resulting in increased excretion of glucose in the urine, and this ultimately leads to a reduction in blood glucose. Additionally, this medication may also help with weight loss, and it is worth noting that SGLT2 inhibitors do not cause hypoglycemia. Looking at the side effects of SGLT2 inhibitors, urinary tract infections and genital fungal infections, such as yeast infections, are more common in patients taking this medication. This is due to the increase in glucose in the urine, which promotes bacterial growth in the urinary tract. Some patients may also experience increased frequency of urination, and this may lead to lower blood pressure due to the loss of fluids. Some patients may also notice a slight increase in their cholesterol values, as well as some nausea.
The EMPEREG study was a study testing the efficacy of empagliflozin in patients with diabetes. And for the first time after 25 years, we have a drug that showed a reduction in mortality and morbidity. But not just overall mortality, but also the occurrence of new heart failure cases. This is very important because of the safety concerns that we had with previous drugs, like the glitazones or some of the gliptins. And therefore, the results of the EMPEREG tell us that we have a new class of drugs that can be safely used in patients with heart failure. Of course, there are new trials ongoing to address specifically the efficacy of the SGLT2 inhibitors in patients with heart failure. And the results of these studies will be important, not just to confirm the results of EMPEREG, that seems to be also mirrored by the interim analysis of the other trials with the SGLT2 inhibitors, but also to teach us how to use friendly these drugs in patients with heart failure. One important point is that now cardiologists are empowered to treat diabetic patients with heart failure. We shouldn't leave diabetes to other specialties, and the guidelines specifically say that patients with diabetes should be supervised by a cardiologist.
My doctor did inform me that diabetes can affect the kidneys.
I was not aware that diabetes was linked to kidney disease, nor has my doctor told me about that.
My doctor talked to me about kidney disease and diabetes once.
My doctors told me that kidney disease is one of the #1 complications of diabetes.
To prevent further deterioration of my kidney disease, my doctor recommended that I do these things.
Stop drinking alcohol.
Lower my daily salt intake.
Managing my blood sugars and my blood pressure, and taking medications called ACE inhibitors to keep my kidneys healthy.
And to eat properly and exercise.
My doctor monitored my progress of my kidney disease, and since it was at an early stage and it was pretty stable, I didn't have to go to any other specialists.
My kidneys are checked through a urine test and also a blood test.
Every 6 months, my doctor checks my kidney function with lab work.
For people with diabetes who don't have kidney disease, I want them to know this. There is always that risk that they could develop it. They need to be careful and they need to follow their plan.
Welcome to the EMPA-Kidney website. About 20 years ago, important trials showed that a group of medications called RAS blockers protect the kidney and the heart. These medications are now widely used and they've meant some people have not needed to start dialysis. However, despite these medications, many people with kidney problems still develop worsening of their condition or heart complications.
In Oxford, we are searching for new treatments to reduce the remaining risk. The EMPA-Kidney trial is testing a medication called empagliflozin. Empagliflozin causes blood sugar, on average about 10 teaspoonfuls a day, to pass into the urine. It also increases the amount of salt passing into the urine. These effects result in a modest fall in weight and blood pressure.
Empagliflozin was originally developed to treat people with diabetes, and in a large trial reduced the number of people with both diabetes and heart disease dying from diseases of the heart. The same trial suggested that medication could be used to reduce the development of worsening of kidney disease. And because of the way empagliflozin works on the kidney, there is good reason to believe it could benefit people whether they have diabetes or not.
So scientists based here at the Medical Research Council's Population Health Research Unit at the University of Oxford are collaborating with scientists and doctors in the UK, Germany, United States, Canada, China, Japan and Malaysia to find out whether taking an empagliflozin pill once a day prevents worsening of kidney disease or death from heart disease in people with chronic kidney disease.
The study aims to recruit about 5,000 people with kidney problems and give half of them an empagliflozin pill once daily, and the other half will receive a dummy inactive pill known as placebo. This will make it one of the largest clinical trials ever conducted in people with kidney disease. Which treatment each participant receives is decided by a computer by chance, like tossing a coin. This is called randomization.
Participants and their doctors will not know which treatment they are given, and the study staff will not know either. This ensures that the study gives results which are reliable and trustworthy. Participants are then followed as they take study treatment for about 3 to 4 years in 6 monthly clinics where they will be monitored.
The EMPA-Kidney website contains more information about the study, so please do have a look around and contact us with any questions. Thank you.